Okay, I think it's recording now,
Okay.
so take it away.
Okay. To share it.
I can see it fine, by the way.
Okay. Yeah. So good evening, Professor. Today I'll be starting with the final presentation of my independent study, which is about Mercurial AI, a AI-powered personalized solution for cancer patients and oncologists. So we see that there's an unequal access to cancer care in the US, which leads to disparities in cancer outcomes. And it is because cancer being a very complex disease, the treatments can be expensive, treatments can have side effects which can be long lasting, and the treatments can somehow be ineffective. And as per the chart which I'm mentioning in the right, we can see that most of the disparities are sometimes because 80% of the Asian population might have higher chances of cancer, and more than double populations of Black population and Hispanic populations can have greater chances of mortality. 3x chances of mortalities are seen for Hawaiian people as well. So all of this, and we also have seen that there is a 43% higher mortality rate for people who are living under persistent poverty. So all of these disparities is because we have a social circle, and this chain is including the socioeconomics, which has like better education. People who are having better income and employment might have better access to the treatments. People who have clinical access or clinical qualities, clinical cares near to their places, or people staying at bigger cities might have greater access to the care. It also comes with cultural, behavioral, psychosocial, biological, and environmental chain cycles, which creates the disparities. And we see that um, it is impacting like around 5,000 new cancer cases arrive each day. And we are seeing nearly 2 million cancer cases in US as of now. Around 2 million new cases are estimated to come into 2023, and around 600,000 estimated deaths are predicted this year. So it's impacting a lot of people, and a lot of people are facing this problem. Um, Going to the market size, we see that uh, considering an average cost for a treatment around 1,000, sorry, 100,000 K, the TAM would be around 150 billion. The SAM would be around 50 billion if we consider 10% of the US market. And taking the 50% of the SAM, the obtainable market would be around 7.5 billion, which is again a huge market to see. Looking at the existing cancer treatments, right now we have five types of cancer treatments, starting with the surgery, which is from the ancient times, going on with the radiotherapy and the chemotherapy, which is most preferable in these times, but comes with a lot of side effects and hardships. And then comes molecular targeted therapies and immunotherapies. Uh, Now we see that what's missing in this. So we want to develop a solution which develops and deploys equitable machine learning solutions that can help to identify and address disparities in cancer care. We are trying to create personalized treatments and equality and equitable solutions for everyone, so that feel that they are being addressed and they know what's going on with the treatments. This will not only empower the oncologist, but the patient will also feel that they are getting a personalized way and a personalized treatment which could cure them in a very efficient way. Looking at the personas, a persona of an oncologist, we are clearly saying that they are facing challenges with requirements, staying up to date with the guidelines. Also, they don't know about background of the patient, like do they want any financial aids or reimbursements, or does the patient has some back history of something else. So all of these challenges are being faced by oncologists, and they feel that they need to have a face-to-face meeting. They need to have dedicated time for patients, detailed explanations for them to make them feel better about the situation and understand it. So they actually, oncologists want to have personalized treatments and create targeted drugs for them, but due to the time constraints and due to all of the regulations, they're not able to do that. And also keeping track of each and every patient and giving them dedicated time is not possible. So once we see that they want to do this, they want to keep privacy, confidentiality, they feel that collaboration with the healthcare team, considering the demographics and individual needs, would also be very beneficial to them. Then looking at the cancer patient, they also feel that even though they are having cancer, it doesn't mean that they are not understanding what's going on. They want to know about what kind of treatments they're taking. Uh, they want to get actively involved in it. They are seeking for techniques. They want counseling. They want to maintain a healthy lifestyle, and they want to get a better treatment which can cure them efficiently. So these are the personas which we can relate to and feel like our hypothesis can be achieved, and we have proved it. The income levels, based on the income levels, it can affect the cancer care. The racial and ethnic minorities which are facing can also get a very better treatment due to the personalizations, and knowing each and every aspect of the patient would help the oncologist treat them better. Private health insurances, which can improve access to cancer care and outcomes. Because most of the times, even though people have insurances, not everything is covered into it, and they're not aware of how much extra they're going to bear. So that might be again helpful if AI comes into the picture and helps them and guides them throughout the process. And especially oncologists, after taking several interviews, we found out that for different races and different locations of the people, it impacts how they wanted to be cared, and how equally and correctly they want to get to know the information. So all of these things were proved, and we feel that the solution which we are trying to build can be very helpful for both the oncologists and cancer patients. Looking at the flow diagram, so we think that after data preparations and anonymizing the data, we can store it in a So we could train the model, and after getting the patient's data from the mobile app, the physician giving the data, it could again make it encrypted data, and then personalize it, store the results, and then they could evaluate the score based on what the notes of the oncologist did, and create a care plan for the patients. Looking at the prototype of the consumer app, we can see that they can get a personalized experience by adding certain checks to it, like appointment reminders, sleep, exercise, optimized nutrition, patient diary, therapies, physician chat. So this feature I feel is most powerful. Like if they have any queries or if they have any doubts, they can just chat with the physician. And it not necessarily means that they have to get an answer like in 10 to 15 minutes. It means that the AI could respond on behalf of physician because AI knows everything. So they might get quicker responses to it. And they could actually get to know a lot of things. And based on the schedules, we can create their entire calendars. We can check mark their prescriptions and whatnot. Looking at the providers app, which is for the oncologists, we can see we have created three color codes. Like first color code would be for the first treatment, the second color code would be for the visits, and other codes can be related to what kind of treatment the person is getting. Based on the reports, they can store all the notes, they can have all the patient reports here. So everything would be given to the oncologists, and they can simply add their notes into it. The reports would be automatically getting to them once the patient is given any tests for it. Then looking at the AI solutions. So based on the doctor's notes, the doctor would be interpreting the texts and would be generating these kinds of uh, instances and create some of the accuracies and tell what should the patient do. So this is just a prototype, so it's not currently 100% correct. But I would say that the results which we are getting to see are average and need some improvement. But looking at the first glance, it seems very promising. And going to the revenue model, we are thinking to go for a subscription-based SaaS model with monthly-based subscriptions and yearly-based subscriptions, which will be used by all hospitals, oncologists, radiologists, and patients. Since it's a two-way app, both for oncologists and consumer, the patients would also be using. Although we plan that the patients would pay a very nominal charge for the app, since we want to make it very equitable, and most of the revenue would be generated from the hospitals and oncologists. The risk analysis would say that we have to be careful about the data privacy, since it's a very sensitive data. We have to look out for ethical considerations. Since AI is into the picture, we don't want any unethical thing to happen because of AI. There comes another picture of regulatory compliances. Since cancer being a very huge disease and people being very sensitive towards it, we don't want any of the things happening due to AI or our solution, and it should not misinterpret or it should not be over relied. Looking at the competitive analysis, we feel that we are at par uh, when it comes to personalized treatment plans and getting an easy access for patients. We are trying to create a merge between both oncologists and uh, patients so that they are on the same page. And looking at the other companies, although few people are creating better reports and all, they're not really focusing on the patient side. They're just focusing on the hospital side, which creates a lesser access for patients, and they don't feel involved in the activity. Um, and then in the future, we feel that we have to get first a FDA pre-compliance, which would take around 3 months of time. We need to launch an MVP since we have our prototype steady. After the pre-compliance, we could easily launch an MVP and we can start testing it in the market. And then the entire product development would take around 12 to 18 months, where we could include all of the features which we are planning to incorporate in. And in the first year, we aim to capture 100 plus, 10 plus hospitals and 1,000 plus user patients, which could get us to know more data and make it more efficient. So that is all. Thank you.
Okay, first of all, who is we? It sounds like you're part of a team. Is this a team that's working on this, or?
Yes, so I'm working with a startup called Mercurial AI. I was interning as a uh, product and customer research. I was part of customer research, customer development, and user experience.
Got it. Okay. Are you planning to work there this summer as well, or
So I had started my internship at Hyatt right now. So
yeah.
this was my first week. So
How do you like, how's Hyatt working out for you? Pretty good?
yeah, it's really nice. People are very welcoming, and I'm quite enjoying it.
Um, so I got a few other questions here. Why is this not integrated with an EMR? For example, Epic Systems has a very, very elaborate EMR, or is Epic Systems a competitor?
No, Epic system is not a competitor. Rather, we would be integrating Epics to utilize the data. So we plan to get all the data of the patients from Epic itself, and then we could be utilizing it for reports and everything which the doctor wants. Since all the data is already with Epic,
So
the
is this like a plugin? You're going to be creating a plugin that uses the API from Epic, or what's the plan?
So that might be, we have two approaches to it. First, directly collaborating with Epic and then getting the information, or then other one would be the plugging one, where we could scrape the data and we could get the information from the Epic.
So do you have to retrain the model for every new patient?
No, since the notes of the doctors would be incorporated for every patient, that would be different for every patient. So we want to create a personalized treatment and make it more in depth for particular patients so that the model gets trained, but it cannot copy the entire same treatment for another patient because every patient would have different things and different kind of side effects or different kinds of reactions to any drug which they're taking.
Got it. Okay. Um, I guess I'm confused as to who is going to need this, right? So if you go to Northwestern Hospital System, they got 14 hospitals, they've got oncologists, they have cancer centers, cancer specialists. Why would they need an AI? Or is this targeting more of the smaller rural hospitals that don't have all of those resources?
So during the interviews, I found out that mostly looking at the comparison, like the bigger city, I have interviewed bigger city doctors, oncologists, and rural city. I would not say rural, but outskirts of Florida, I would say. So I found out that uh, both of them were having the need of this, and it was that only reason why the Florida one would say that they would really want it because some of the patients really come from far away and don't have that much of good access to better hospitals, and that might sometimes create an impact on how they are treating the cancer patients. Like, let's say if the patient is traveling from far away, 2 hours, and then they're getting it treated, so maybe the patient would already be exhausted and not get the same treatment. Whereas if the patient is nearby a bigger hospital, it feels more accessible to get all the tests done, to meet the doctor regularly, and so somewhat like that. So we felt that there's need for everyone because AI is there, but it's in a laptop. It is in an app, and oncologists are going to utilize that AI to make better treatments. So both the city doctors and the rural doctors would be needing it to create efficient notes and utilize AI to see reports and generate the plans in a better way.
So this is a tool for the oncologist. What if AI recommends a procedure or a treatment plan that cannot be supported by the healthcare provider? They don't have the equipment, they don't have the training. What then? I mean, it seems like you're recommending them to go somewhere else, right?
No, so based on the technology they are using, based on what tools and equipments they have, they would have already filtered those things. Like for a surgery, what all things are needed, and they would have checked that these are the things which they have in their hospital. Apart from that, the app would not recommend anything else. And if they are open to anything or any of the solutions, then maybe AI would give them better solutions. But then if they've restricted themselves and filtered out, so then the AI would give solutions based on those things only.
So do you see the conflict here? I mean, if I were the customer, a patient, and if
Yes.
I wanted a subscription to this model and to this tool, I would want to know the best treatment, uh, period, independent of location. If I have to fly to Minneapolis, if I have to fly to San Francisco, I will do it. I'll even fly to Thailand if that's the best place for treatment. So is there a way to make two versions of this? One that's more patient-centered, that's location independent, people who are either wealthy enough or I guess interested enough in getting the absolute best treatment versus the caregiver who's very interested in getting another patient, right, for their system.
So I think
You see the difference? You see, hopefully you see the difference.
I see the difference, but I feel that um, we have to take a step back. Like, we do not want to show all of the solutions to the patients directly, because the patient might feel like, okay, I have a better treatment over, like, they can fly to Minneapolis and get a treatment, but that won't be feasible, and that might not be the best way to operate. So we want that it goes through the path of oncologist.
But it might be a possible, and it might be the best way to go. If I can afford a $500 airplane ticket, if I can afford to get treated in Minneapolis, why, and if that's going to have a better outcome than Chicago, why wouldn't I go there? Why wouldn't your tool let me go there?
Because we are creating a pathway, like it should go from the oncologist to the patient. Like oncologist first will write out their notes, and based on their based on their notes, a personalized treatment and a checklist would be created for the patient. Any which ways, patient would be very confused. Like if at all we are saying that you have the best treatment at Minneapolis, and you have to fly and you have to reach there, but the chances of it getting, like, the person getting to know everything about it would also be less, because again it would be the same treatment which the oncologist will be offering. It wouldn't be very personalized. What we are trying to do is making it more personalized so that it goes through the path of oncologist, and then it makes like an easy checklist. Like we just saw the prototype, so it would be like easy basic checklist, like you have to sleep at this time, you have to do this. Maybe if you get to know the better treatment, that won't be that personalized.
So I'm going through something with prostate, and I'm trying to get prostate treatment, and I looked up the most modern prostate treatment there is, which is called aquablative. So from the aquablative, I went to my physician and I asked him who in this network can support aquablative. There was one MD who's doing this kind of procedure in all of North Shore University Health. And then I got an appointment with that doctor, and I'm now scheduled for that kind of surgery. So I think there's two different approaches. One that is driven by the oncologist, right? And one that's driven by the patient. And more, you're seeing a shift towards the latter. You're seeing a shift towards patient-driven choices and patient-driven, I guess, searches. So, especially when it comes to cancer. I mean, there's story upon story about people who will travel all over the world to get the treatment they need. I mean, if you're talking about $100,000 treatment, a $500 airplane ticket to Minneapolis is trivial, right?
Yeah.
So why wouldn't the patient want to get the very best outcomes using the very best procedures? And why wouldn't your tool, because your tool could be trained either way. You could train it to confine themselves to just what this hospital group can deliver, or you can train it to basically scan the world. And it's literally like flipping a switch, right?
Yeah, but then a thing would be like the market size would shorten like with a very limited group of people who are very I think who are very
I think
uh
what this is the problem, it destroys your business model.
yes.
That's the problem. Your business model is you're selling to a hospital group, you're selling to physicians, and they're not going to like what I'm saying. They would reject it the same way you're rejecting it, and largely because it drives business away from them.
No, I mean the people who can afford um very expensive treatments and the people who are willing to pay us same amount of money, that target segment would be a very less compared to the hospitals, I would say. Like, I think in 2 million people, around 10,000 might be willing to go to someplace else for their treatments, but most of them would like to stay in their comfort zone and then get a treatment.
Okay.
So that would reduce the revenue for us and giving them, even though if we are charging a very heavy price for them, it would not generate any profit for us.
Does your system need to be approved by FDA?
Yes.
So where does it stand in that FDA approval process?
So right now, we are planning to apply for it. We haven't applied for it. Once the prototyping is done and the first round of iteration is complete, we'll be filing for it.
Got it. Okay. So you're years away from being in the market.
I think so, but sometimes the FDA approvals can be done quickly as well. So fingers
Okay.
crossed.
Okay. Um, let's see, what else have I think you've answered all of my questions. I guess for HIPAA is my last question. You talked about anonymizing the data before you retrain the model. There's much more to HIPAA compliance than simply anonymizing your training model, right? Your training data, correct?
So I would say that this is because to encrypt the data and not uh, the compliance comes into the picture, and we don't want the data privacy to be uh, get breached anytime or anywhere. So that is why we have thought of this step.
Got it. Okay. All right. Well, thank you. I think you've done a great job here. This is fascinating work. I'm curious. I mean, everything you showed me is work you've done, not necessarily stuff that came from Mercurial, right? This is work you did for Mercurial, right?
Yes,
Okay.
yes.
So it's above and beyond anything that you inherited from the company when you started, right?
So I just had this problem and some of the ideas, but most of the things I have incorporated and I've taken around. So previously during the midterm, I had taken around 6 interviews, but then I took around 17 interviews, and then now we were thinking of taking interviews of cancer patients, but now since I have joined Hyatt, so I couldn't be part of it, but they are planning to interview cancer patients as well to see how it can be. I think there was some challenge to it because the cancer patient, I think to interview the cancer patients, there should be some approval to it, which they're not able to get.
I see. Got it. Okay. Yeah, I would think that this kind of interviewing process, eventually you're probably going to need some sort of IRB, right? So I think I'm sure they're talking about getting an IRB approval. Are they working out of a university system, or is this Northwestern, or what? Whose university system is this?
Uh,
Or is it independent of universities?
yes, it is independent of the university.
Okay, all right. Healthcare and hoteling are very different. I guess I'm curious. I know you've only been in hoteling for a week, but where is your passion? They've got to be, I mean, these are radically different industry sectors, right?
Yeah, I think I'm enjoying the hospitality sector sector right now.
Okay.
And there's a lot to explore. So we are having some good kind of talks. Like today we had a talk which said how Hyatt makes money. So that was quite interesting. And there are lawsuits going on. So that came into picture. So all of the things, so it's good to know. And one fun fact is they have advance bookings up to 8 years. So I was shocked by getting to know that.
So how does Hyatt make money? I'm assuming that they make money by renting out their rooms every night.
Yes, they do, but they have three kinds of models. Like they have own hotels, they have managed hotels, and they have franchised models. So hotels. So they are focused right now on the managed hotels more, and then shifting their owned hotel business to the sites. Since most of the revenue is getting from the managed hotels and the franchised hotels. Uh, and with their competitors as well, like Marriott and Hilton, both are looking at the franchisee models. So Hyatt is doing something different and going for the managed hotels approach.
And the franchise model, I assume, charges rent. Do
Yes,
they own the property and they charge rent to the franchisee?
yes, you only get the base fee commissions through the franchisees.
Okay. And who owns the properties?
There are third party owners for that.
Okay. Okay. So it's not Hyatt themselves.
Yes, you just get the brand name for it.
Got it. Okay. So you're licensing that brand name.
Yeah.
Effectively, you're paying a licensing fee.
Mhm. Yeah.
Okay, sounds good. Anyways, thank you. I hope you enjoyed the project this quarter.
Yes, I did. And also, Professor, just one request which I would like you to consider. So since I was taking a lot of interviews and I was not able to get enough data for submitting it like on time. That's why I was not able to submit in my some of the assignments got delayed. But that was purely because I was not on track. But because when I started the independent study, some of the things I took a lot of time gathering the data, which caused the delay. So I would just request you to consider
Okay,
it.
I'll take that into account, but I mean, recognize that everyone was under the same timeline as you. And I see that I haven't graded the final report, but all your other grades look, I mean, yeah, they were discounted a little bit, but not dramatically. So yeah, I think we'll see what happens. But I mean, I think in general, I have to deduct for lateness regardless of the reason. So
Okay.
yeah, but anyways, I wouldn't worry too much. I think what's more important is what you learned from the process. In a sense, this was a product management type project for you, right? You were doing product management work, so you should be proud of it and publish it on your LinkedIn and also put it on your kind of like your resume, your professional resume for people, so they know that you've done this and this is something you can share with future employers.
Sure.
Okay. All right, Jagruti, thanks for your time tonight. I appreciate it.
Thank you, Professor. Thank you.
Take care. Bye-bye.
Yeah. Bye-bye.